So get comfortable, guys. I don't think you're going to have to exercise, those people who are signing up, but I'm sure you can get up and jump around if you wish to during the webinar.
Yeah, maybe we can have the boogie at the end.
The boogie at the end.
You never know with Angelique and Shelley what she's going to make you, what they're going to make you do.
Well, every time we say the word exercise, you need to sit up and down out of your chair.
Yeah.
No.
Okay. I'm Catherine. Okay.
No, we can't see you, just on audio, so you can be in your pajamas.
Yeah.
Or your gym clothes.
Or other.
Cheeky.
Well, we intend to have fun today with this webinar. We've got participants
never had fun.
signing up quite quickly, and we had a lot of over 100 people interested in this webinar. So we're just giving a few seconds for people to, a few minutes for people to just sign in, and then we'll start.
Pajamas are the new gym clothes. Yes, they are. Hi, it's Jenny. Hi, Jenny.
Catherine, too much detail.
Oh, sorry, I shouldn't read it, should I?
No. That's good. That's interesting. Yeah. If you're doing the radiation burns things, it's top off. We can't see.
Okay. So people are still just signing in. So we'll just give it a few more minutes and then I'll introduce these beautiful women to you. I'm Judith.
I love that.
We're getting some fun chat messages down here.
Great.
Realise that chat is visible to everybody, just so you know, guys.
Oh, I should close it then. Hey.
Why don't we start? So we've got quite a few people who have joined us, and there's still people joining in, but I think we'll just start and I'll introduce myself. My name's Judith Lacey, and I'm the medical director in the service and the head of supportive care. And welcome to our Living Well with Cancer webinar series. We started this series at the beginning of COVID, when we realised it's really important to connect with people and connect in this new space, and it's been really quite successful. We've had fantastic attendance to our series, and hopefully you'll enjoy this discussion today. So we're going to discuss the benefits of exercise and how it can assist patients during their cancer journey and beyond. We all know that in 2018, COSA issued a position statement, as did ESSA, on exercise in cancer care that called for exercise to be part of standard cancer care as an adjunct therapy. Exercise is great for helping patients cope with symptoms and side effects of treatment, and you'll hear a lot about that from Dr. Shelley Kay and Angelique Tambakis, who are here today. A little bit about this series before I introduce these beautiful people who are my dear team members. This series is brought to you from the Living Room, which is the home of supportive care and integrative oncology here at Chris O'Brien Lifehouse Comprehensive Cancer Centre in Sydney. At Lifehouse, we aim to provide cancer treatment in a way that supports, nurtures and empowers patients, their families and carers through mutual beneficial partnerships. Integrative oncology and supportive care as part of this holistic supportive care delivery forms an integral part of Lifehouse's comprehensive cancer care, complementing clinical treatments to improve patient outcomes from the time of diagnosis throughout treatment and beyond. This series complements other webinars and podcasts that are out there, and the opinions expressed on the webinar do not necessarily represent those purely of Chris O'Brien Lifehouse, although we are Chris O'Brien Lifehouse, and not in place of medical or healthcare professional advice. So it's really just to inform. And with that introduction, I want to introduce our two wonderful speakers today. Dr. Shelley Kay is an accredited exercise physiologist with a background in education, research and clinical practice. Her doctoral research focused on how exercise impacts fat, muscle, bone, brain, and metabolic pathways related to disease. This informs her approach to implementing exercise medicine for oncology patients in supportive care, in our supportive care department. She's passionate, she's bloody passionate, about exercise medicine and caring for oncology patients. She is. And then there's Angelique, who is an accredited exercise physiologist who has worked in private practice, musculoskeletal, cardiac rehab, clinical research trials, occupational health and aged care, and is a mother of a beautiful 1-year-old. She's called Lifehouse home since 2018. She's passionate about a lot, but she's also passionate about education and empowering individuals. She loves her role at the supportive care department, dancing through exercise classes and enabling a nurturing environment for all of us. And what we're going to do today is, I'm just trying to move my little note that I had there. So we're going to start off with 2 short presentations of about 20 minutes each. Shelley will start and Angelique will follow, introducing this concept of exercise as medicine and give you a bit of insight and understanding as to why we're so passionate about the importance of exercise in cancer care from the time of diagnosis on. There's the chat button where everyone's told us about their pajamas and their sorbeline dressings, but then there's also the QA button, which you can write your questions, and then we'll have about 20 minutes at the end and we'll go through some of those questions and hopefully be able to have a question response time and a bit of a discussion on this topic. So I'd like to start by introducing Shelley to share her screen and start this webinar.
Hi everyone. So the topic of today is exercise is medicine. Exercise is a polypill for the prevention and management of many diseases. And just like conventional medicine, different pills and doses target different conditions, pathologies and risk factors. For example, if increased muscle mass is the target for reducing chemotoxicity in a cancer patient's journey, then there's only one prescription. There's only one anabolic stimulus for increasing muscle, and that's resistance training. And walking won't do it, and core stability won't do it. There's a type and a dose for exercise medicine, but it won't work unless the medicine is taken regularly. So if exercise is the pill, muscle and bone are the pill factories because they regulate a symphony of chemical reactions that regulate cell growth, function, and repair, and set up communication between organs and cells. Sedentary behaviour sets up an environment with less muscle, more fat, particularly around the abdomen. That leads to more glucose, fat, and insulin and growth factors circulating in the blood, and more sex hormones. And that leads to increased inflammation. And the science tells us that many cancers actually thrive on this pro-tumour environment set up by sedentary behaviour. Systemic low-level inflammation is a feature of ageing, cardiometabolic disease, and some types of cancer. Exercise affects every tissue from the brain to the nerves in the toes, and when your muscles contract, it activates the release of thousands of substances, including myokines, that counteract this inflammation from a sedentary behaviour. There are a number of myokines, and some of them are implicated in the way cancer cells can grow. Now, we look at cancer. It's the multiple hit, and we never know what the one piece in the puzzle is that may set a cell off on a trajectory that makes it go crazy, goes rogue, and we don't know what the puzzle piece is that might actually keep it healthy. So every cancer and every subtype is different. However, in some cancers, exercise can modify the known risk factors. Perhaps it's inflammation, perhaps it's growth factors, perhaps it's sex hormones. But would this be enough to modify the disease? Well, exercise oncology has been investigating this for a long time, We think it's new, but the first study looking in animals, how exercise inhibits tumour growth, was published in 1944. Now, at this time, we have very limited evidence to make claims about the effects of exercise on cancer. And it's not because we don't have people who want to do the research. We have a growing body of evidence, but it's not at the volume and the standard that allows us to make claims that exercise can cure cancer. It certainly can't. It's a helper to all the traditional mechanisms for approaching cancer. And it will likely, as we follow forward in the next few decades, gain a little bit more funding, we hope. But that's really putting it in context. We have a lot of interesting information. It informs the way I think about it, but it really isn't at the status now of the traditional medicines. But something is definitely happening. For example, in this study, prostate cancer cell lines were incubated in a serum of 10 men before they exercised. And you can see from these bars here that those cancer cells continue to grow. Then, after the men exercised, their serum was collected, and those prostate cancer cell lines were placed in the serum, in the dishes of the men, from the men who had exercised. And 9 out of these 10 samples shows that the cell proliferation was somewhat inhibited. Well, that doesn't tell us anything about the effects of exercise on cancer. It does tweak the interest into something is happening here. Something is happening in the blood of people who exercise that has this effect on cancer cells. So what about genetic risk? We know that we can't change our genes, but exercise can actually change some of the messages that the genes send to the rest of the body. This is a really interesting study. On this panel here with the orange dots, it represents people who had low genetic risk based on 53 risk variants. And here we have people who had a high genetic risk. So we've got the low and the high genetic risk. Each of these dots represents a lifestyle factor such as diet, alcohol, smoking, exercise, and body fat. And the more of these lifestyle factors that are in place, it reduces the risk of cancer occurring. You can see there's no difference between the low and the high risk for colon cancer. So lifestyle factors have a really big effect regardless of genetic risk. So something's probably happening there. And this is an interesting one looking at those mutated genes that are well known with breast cancer, the BRCA1 gene. And it's also related to prostate cancer. And this study looked at the differences between sedentary women and those who were more active in the number of normal BRCA genes that were expressed. This study shows that active women express more normal genes compared to women who were sedentary. And that was interpreted by the authors as potentially knocking down the effects of a mutated gene. So if you have a lot of healthy genes, perhaps that will have an effect on the way a mutated gene might take over in anyone's body and system. So it's just an interesting part of the way exercise can influence the way genes are expressed in the cancer environment. Also in prostate cancer, in men with on active surveillance, more than 3 hours a week of vigorous physical activity versus those who were inactive. This study showed that there were a lot of repair pathways upregulated. Now, the way I see exercise, it does a little bit of damage and you send in the repairman. You get stronger. A little bit of damage, send in the repair guys. You get a little bit stronger. And this could be something that explains part of that mechanism where we're observing that a pathway of repair was activated by vigorous activity. A lot of observational studies are showing that those who are active after diagnosis have a lower risk of their cancer coming back. Now that's only from observational studies. It's looking at people who are active and comparing them to people who are inactive after diagnosis, but it doesn't tell us that exercise is doing something directly, but we're looking at people who are active and they tend to have less of the cancer come back. that's a really good thing. And in this study, the green bars represent slow walking, here for less than 7 hours a week, and here for greater than 7 hours a week. The key feature here is that men who are walking at a very brisk pace, that it's a higher intensity, for more than 7 hours a week, have a much greater reduction in their prostate cancer mortality than doing very slow walking for under 7 hours. So intensity and volume at that 1 hour a day is actually having a greater effect. And in women after breast cancer, the Nurses' Health Study, which has been ongoing, very large sample size, shows that women who do 150 minutes or more of moderate intensity physical activity have a reduced risk of their cancer coming back compared to sedentary behaviour. And in colon cancer, after diagnosis, without any knowledge of what's happened before diagnosis, like irrespective if someone was active before, people who are active compared to those who are sedentary have very different survival rates at 5 and 10 years. So that's really good news. Seems that exercise is doing something in that relationship between activity and reducing the risk of recurrence. So that's the survivorship, secondary prevention. We also know that exercise and physical activity has positive effects before, during, and after treatment. There are lots of different types of treatments. It can be chemotherapy or radiation up to surgery and then another treatment after. It could be many combinations. But the role of exercise in that lead up to the treatment or the surgery is becoming really important. For example, good exercise has been shown to reduce the risk of surgery, and that's probably due to the enhancement of immune function. It can account for the amount of muscle that you lose when people feel quite unwell or they're very tired going through their treatments. We can counteract the loss of muscle or at least minimize the decline. And this immune status and its relationship to aerobic fitness as measured by CPET is predictive of mortality and morbidity post-surgery. The Macmillan Cancer Group in the UK focus on this, and they show that prehab offers personal empowerment, sense of control and of purpose, and it helps people develop resilience in this very difficult pathway. Well, here's an example of people waiting 4 weeks to have their surgery from metastatic colon cancer that is gone to the liver. And in all of these areas of physical and psychological health, in 4 weeks, there were pretty much no change at all. And there was another group who exercised, and they did high intensity interval training on exercise bikes for 4 weeks. And you can see that the changes from the baseline with these blue the blue lines here, the dotted lines, compared to the pink, which is the time at 4 weeks, shows there's an improvement in physical function, an improvement in pain, in vitality, social functioning, physical, emotional, overall physical and mental health, and quality of life. So they're really notable changes as a result of just 4 weeks of getting on the bike before you had your surgery. I'm really fascinated in the mechanisms that might explain why exercise can synergize and be a helper medicine with the traditional treatments such as radiation, immunotherapy, and chemotherapy. And there is evidence suggesting that it might actually enhance the outcomes of these treatments. Exercise during chemotherapy is probably going to be very hard, and it may not be possible for all people. However, it can help maintain the immune system. It can help people tolerate their treatment so they can complete all the doses, so they can have their maximum chemotherapy. It can help to maintain muscle. While chemotherapy damages all the cells, the good cells and bad, exercise is sending in the repairman to do as much as it can to repair the damaged healthy cells. One of the reasons why exercise oncologists believe that exercise can help the chemotherapy work better is the effect of exercise on developing healthy blood vessels. Now, when people do running or they do weight training, they have an increase in the number of their blood vessels. that's a good thing, delivers oxygen, takes away lactate, really helps the whole delivery of the substrate for the energy for the muscles to work. So cancer cells really like to use substrates. They like fat, they like protein, they like glucose. And when chemotherapy is being delivered, they have a blood vessel system that is leaky and it's irregular. And that can sometimes block the chemotherapy going into the cancer cells. So what exercise is thought to do is improve the type and the health of the blood vessels so that the chemotherapy can really target those cancer cells. Now, what's really interesting, probably just a few months ago, instead of it being an animal study, because that's never enough in the cancer world, there were human studies in pancreatic adenocarcinoma. And in this group, there were a group of patients who were doing their prehab while they were doing their chemotherapy, their neoadjuvant chemotherapy. There were also, some of them were having radiation. And then they had their surgery for the pancreatic cancers. And in a number of people, those cancers were analysed. And this study showed that the number of blood vessels in those people who exercised compared to those who didn't was greatly increased. And the density of the blood vessels in the exercising cancer tumours had, the density of the blood vessels was higher. So that idea that exercise had an effect on the tumours by normalising or increasing the blood supply to the tumour to help the permeability of chemotherapy into the tumour is borne out by this particular study, showing that that could be a possibility. In radiation, there are no human studies, but in the animal studies, it shows that exercise before and during radiation in rodents demonstrated a higher number of the immune cells and natural killer cells, and they were infiltrating the tumours in the mice. These studies also showed that in the exercising mice, there was a slowed tumour growth and there was a delayed metastasis. Now, again, that shows that there is something going on. There is an effect. It's not showing that exercise is curing the cancer. It has to be the radiation, and it looks like exercise is probably going to be a helper. So that's a good thing, because we know that natural killer cells and immune cells are really going to help in the fight against cancer. So this is a lovely study of stomach cancer patients, and 2 days after their surgery, can you believe it, they were exercising with a foot or an arm bike, half an hour moderate in the morning and half an hour moderate in the afternoon. The green lines show the control group who weren't exercising, and their natural killer cells, those cancer-fighting cells, the immune cells that help you get better after a surgery. At 7 days, they weren't much different from the exercising group. So at 7 days, nothing was going on. But when you look at this exercising group at 14 days, the natural killer cells in the exercising group after their stomach surgery was more than 2 times the amount of the non-exercising. So that supports the concept that exercise enhances the immune system, and that could help people recover better from their surgery, and perhaps it can help their cancer treatments work better. One of the things about the side effects of treatments, and they're really tough, is that people might feel fatigue, nausea, pain, they're anxious, they're depressed, and that leads to inactivity, that leads to more fatigue, more inactivity, more fatigue, and it's a vicious cycle. So with the treatments and inactivity, there's a loss of muscle, strength and function, aerobic capacities, the ability to do activities of daily living. There's often more depression, joint stiffness, and disruptions to sleep. That can be counteracted with good exercise. That means the right amount for the person in relation to what they're going through. With aerobic and resistance, you can increase muscle mass, stress and function, and you can help some of the joint pain, you can help with sleep. So it's a really good helper for many of the side effects that people experience with cancer treatments. Now, this cancer-related fatigue is defined as something that is not relieved by inactivity or rest. This fatigue is related to the cancer itself, the cancer treatments, and exercise can counteract some of the fatigue as a result of the cancer treatments. You can also have fatigue related to pain, anemia, some other health problems. Certainly inactivity leads to fatigue, emotional stress, sleep problems. And exercise is a counterbalancing force to the effects of these other factors on the cancer-related fatigue. In fact, research in systematic and meta-analysis shows that when you see averages of a number of studies, and they all move to the left here, that shows that exercise reduces fatigue and reduces depression in people going through cancer treatments. That's a good thing. One of the difficult symptoms from some chemotherapy treatments is chemotherapy-induced peripheral neuropathy. It can be painful, it can be numb, it can be hot, cold. There aren't a lot of studies, but there is a lot from other disease, from neuronal decay or diabetes, neuropathy. So we learn things from other diseases. But in this small amount of evidence, this particular study, with 170 exercising and 185 controls of different cancers and types and stages, show that the exercise groups in the red have a reduced severity compared to non-exercising. So numbness and tingling was less in the exercise compared to the non-exercising group, and hot and cold sensations in hand and feet was reduced in severity in the exercise group compared to the non-exercising. So that's really hopeful. Again, it's a helper. It's there to just knock down the severity of the symptoms. And that's one of the tools we have in the box. So what's the exercise prescription for the peripheral neuropathy? Well, we look at the big system, because you know if you have a lot of glucose, lipid, insulin in your system, that's not a good environment for nerve cells to be healthy and grow. So we look at the big system with healthy, active, aerobic resistance, and we look at specific training. So this is what we do in the gym. We have a ball for finger flexion. We have these for finger extension. So we're doing the finger workout. We do the foot workout, do a little bit of jumping or a little bit of throwing the ball. And the addition to the exercise prescription is the advanced balance training. And it has to be progressively challenging in order to allow the brain to rewire to a numb foot, to work out a different way for the body to work out how to keep you upright. Face plants are no fun, and they're just off the list for people going through their treatments. We want you to stay upright. We want you to stay healthy. A lot of people going through cancer treatment, and a lot of people even before their treatment with cancer, report that this chemo fog or the chemo brain is really disturbing. And while there isn't a lot of really good gold standard evidence saying that exercise is going to reduce the chemo brain, there's a few randomized controlled trials that show that exercise is a helper. And from a lot of the muscle myokines that are released in exercise, some of them are known to be involved in regenerating and repairing the nerve cells in the brain through the body. So the myokines from exercise are known to help regenerate nerve cells, and maybe that could play a role in the damaged nerve cells from the treatments that result in chemotherapy-induced peripheral neuropathy. Again, probably a helper. So unfortunately, one of the difficult side effects of the cancer treatments is some damage to healthy cells, the mitochondria, the little furnaces in the body. And along the way, some of those cells in the heart are also damaged. So what do you do with heart disease? Well, we've got decades of research that shows that exercise really helps to counteract the negative effects of disease on the heart. And a very, very good white paper was published looking at chemotoxicity as a result of the cancer-related therapies. And you're not crazy if you think that it's aged you, because the damage to the heart is similar to about a 10% decline in aging of your heart compared, a 26% compared to a typical 10% decline every decade with normal aging. So it has created a hit to the health of the heart muscle in some treatments. But what do you do about that? Well, exercise medicine. People going into their treatments often have risk factors such as obesity, hypertension. You've got your next hit, which is the treatment. And the next hit after that would be if there's inactivity after or during treatment. And that's going to create another hit to the health of the heart. And that can be counteracted by aerobic and resistance training. As I said, a lot of research shows that exercise of all types consistently improves cardiovascular endpoints regardless of the disease. But research shows that people respond in very, very different ways. For example, in the HF Action trial, 12 weeks of aerobic exercise resulted in about a 50% change on average. But the range was an 83% deterioration to a 97% improvement. So that shows that people respond differently with exercise to damaged or heart problems as a result of their treatments. And in prostate cancer, there was a report of around about 9% improvement in their heart health, but the range again was between an 18% deterioration to a 32%. So what do you do when the exercise medicine doesn't work? Well, you just tweak your pill, you change your dose, and you change the stimulus. That's what we do. And that's what we would do in working with anybody, which is lots of people in our clinic that have this as a result of their treatments. The important thing is you shouldn't stop exercising, even if your heart has some problems. We get advice from the physicians. We want you to exercise. We want you to exercise safely. So what's the exercise prescription for muscle, bone, and metabolism? It's progressive resistance training. It's the only exercise medicine to increase muscle, and it also increases bone mass. When people have pain, they often think that's not for me. There's a lot of ways to adapt strength and resistance training for joint pain and for limitations. The exercise prescription for bone loss, either from cancer-related treatments or osteoporosis or aging, is resistance training plus impact. Sometimes that needs to be modified because the person has a lot of bone loss, so they have joint pain. But it's our job to modify that dose and that type of your exercise pill. This is an excellent study looking at really good osteogenic exercise principles in modifying bone density in the spine and the thigh. So the blue bars here represent the loss of bone density in the lower back with flexibility training. The pink squares here represent the slight increase in lower back bone density with really good resistance training and jumping and impact training in the exercise group. Now, it's really hard to increase bone density, and if you can do it, it's great. Sometimes your aim is to, Sometimes your aim is to just maintain or minimize the loss, but the osteogenic principles are clear. How it's modified for individuals, that's a skill. In the hip, the study shows that with flexibility training, there was a reduction in bone mineral density, and with the impact training, there was a maintenance. So even in women on bone depleting aromatase inhibitors, there's still a benefit from exercise, good exercise, the right prescription on maintaining or improving bone density. So women on these hormonal therapies have a lot of side effects. The really great news is that exercise can counteract a lot of loss of muscle. In this study, there was 3 different groups. One was resistance training plus a high-intensity interval training on a bike. The other one was aerobic training continuous with high-intensity interval training on a bike. And they were both compared to usual care. In the usual care group, This is an example of your endurance muscles. So how well the muscles have been maintained. In usual care, women on the cancer therapies with usual care have a reduction in the amount of their aerobic muscle fibers, whereas aerobic and HIIT maintained or slightly increased, and resistance training plus HIIT increased the size of these aerobic muscle fibers. In the strength fibers, these fibers here are the ones that give you sprint, strength and power. In usual care, there was a loss of the strength fibers. In the aerobic plus interval training, there was a maintenance, a slight reduction, but in the resistance training and the interval, there was a significant increase in the size of the sprint and strength muscles. So that's powerful. The message there is that doing nothing, you will lose your muscle mass. You'll lose your engine. You'll lose your metabolic system that keeps you going, whereas exercise can counteract and even improve it, even during chemotherapy. And these show that even when exercise is damaging some of the cells, you can still have exercise create new cells, these satellite cells, and more blood vessels in the muscle. The message is that good exercise counteracts the decay in skeletal muscle caused by chemotherapies. In prostate cancer, in men taking the hormonal therapies, less than 3 months compared to more than 3 months, there's a reduction in measures of aerobic fitness. So the longer men are on the hormonal therapy, it appears that there's a greater reduction in their aerobic fitness. Again, in a study of 6 months of aerobic plus resistance training, it maintained aerobic fitness. It had a good metabolic effect in increasing the amount of fat that was oxidized, reducing blood glucose, increasing muscle, reducing the fat around the belly, and decreasing percent body fat. So despite the effects of the hormonal therapy, which makes many challenges for men, a good amount of exercise had a positive effect. Now, hematological cancers are very difficult. People go through severe chemotherapy regimes and might end up having a stem cell transplant. And they live with a lot of toxicities for the heart, as well as lingering chemotherapy-induced peripheral neuropathy. In this study of lymphoma patients, and here we have non-Hodgkin's lymphoma and indolent, that's in remission, non-Hodgkin's lymphoma, and Hodgkin's lymphoma. And this is the change in aerobic fitness here. In usual care, there is a loss of aerobic fitness. But in those in the yellow bars who exercise for 12 weeks, supervised, gradually increasing exercise intensity, all of these groups increased their aerobic fitness compared to those who did nothing and lost. And this applies in those on or off chemotherapy treatments. In addition, this is a measure of anemia. And in the usual care, there was a slight improvement in anemia, but a much more dramatic improvement in the exercising groups. And that applied whether it was on or off chemotherapy. That's really good news. In addition, the results of this study showed that there was improved quality of life, there were improvements in fatigue, happiness, which is a good thing, improvements in depression and lean body mass. So that's also demonstrating that good exercise medicine, even after very difficult treatments, has much superior effects in maintaining and counteracting than doing nothing with usual care. In our group in the living room here in O'Brien Lifehouse, our hematological groups demonstrated an improvement in their walking, their chair stand, their strength, their fatigue, and their balance, and their left and right. So I think that's a good summary in showing you some of the science behind how exercise can counteract some of the negative impacts of cancer, the negative impacts of cancer treatments, and can really help in improving health no matter what stage of the trajectory you're on. So I'm going to hand it over to Angelique now, who's going to talk a little bit more about translating some of that research into really good exercise medicine.
Thank you so much, Shelley, for a really fascinating presentation. We have gone a little bit over time, which is a little bit less time for questions, but we're happy to stay on for another 10 to 15 minutes afterwards for those people who want to talk a little bit more. That was great, Shelley. I'm going to introduce Angelique, and am being mindful of the time, but also excited just to see and to get to some of the questions. Please use the Q&A little button to ask your questions. I was thinking what to call it. Over to you.
There's already a few there. I was sussing them out. All right. Hi, everyone. Just going to start with the position statements that both the Clinical Oncology Society of Australia and our governing body, Exercise Sports Science Australia, came out with in both 2018 and 2019. So in 2018, COSA called out for exercise to be embedded into standard care. And the big thing there was to, I guess, avoid inactivity. Now, what is the exercise prescription? How much? What are we doing? And they aimed for 150 minutes of aerobic exercise and about 2 resistance training sessions per week. And I guess everybody's very different, and that might seem a lot to some people. Others, it might seem not enough. And I guess the big thing for us is to individualize that approach and that treatment plan for our patients. So we want to promote physical activity and exercise. We want them to adhere to guidelines, but it means that they have to be individualized to that person and each person coming through that door. And I guess best practice in cancer care would be to refer to either an exercise physiologist or a physiotherapist who has that experience in cancer care. Now, part of that is, as health professionals, we need to discuss the role of exercise, and that just doesn't come down to us exercise physiologists. That will come down to doctors, nurses, everyone that's part of that treatment process and aiding the patient into recovery. And moving from that is, the big thing, again, I'll say, is the experience of the health professional. Now, we want, if you're going to go to your doctor, they're going to talk to you about your general, your GP, talk about general practice. With the exercise, we talk about our exercise prescription. And we want to learn a bit more about and know a bit more about your diagnosis. We want to know what stage of treatment you're in, any symptoms and side effects that you may be experiencing. Anything cancer specific, so maybe it is fatigue, maybe it is the peripheral neuropathy. So these things are really important to us when it comes to prescribing exercise. So our association also came out with a position statement in 2019, which definitely agreed with the 2018 statement, but in addition, it was all about the individualized approach. It's not one size fits all. We can't say that 150 minutes and 2 sessions a week is for every single person, but it is used as a guide and it is an individualized approach. So moving on to, I guess, referral pathways. When we see patients here at Lifehouse, generally they either come from the specialists or the nurses that are sent through a referral, but your GP can be involved as well. And the idea is to screen for these cancer comorbidities and exercise contraindications, which might be heart-related issues or bone metastases. And that's really, really important information for us to know moving forward with your exercise prescription. Following that, come and see us. So an exercise physiologist, which will be great prior to you commencing exercise if you haven't been exercising before. The idea here is to, again, set some goals, understand the individual, where they are in treatment, what's going on, what are barriers that are stopping these people from exercising, and also understanding, I guess, what it might not just be the typical, oh, I'm lazy. It might also be that fatigue is really, really, overbearing, or the pain is just too much and I can't get out of bed. So we have to start really basic. From there, you may be part of a hospital or a community exercise group. Now, most of these groups can or will have an education component as part of it. I know that in talking in the survivorship world, the Enrich program run by the Cancer Council, they offer both a educational component for both exercise and diet. And sadly, because of COVID, they are no longer doing them for the rest of the year. However, it is a really, really good and free program to be part of if you want to start somewhere. Here at Lifehouse, we've got amazing groups. They're pretty much at full capacity. Hey, Shelley.
Yeah.
And we have a lot of fun in there. There is, everyone has their own individualized program. They'll go from a mixture of strength training and aerobic training, a bit of balance, bit of stretching, but a lot of fun. And most importantly, from, I guess, our perspective, is that social and emotional support that each patient shares with one another, and it is quite empowering to see. It's quite beautiful to be part of, and we enjoy each day with our patients. So I wish they could pop up and say yes, and I will show you a clip later, which will be a little bit of fun, talking about our groups in particular. So I guess what to expect in our consultations. I love that Shelley showed us the why, and why exercise is so important. And, most people just come in and they'll say, oh, my doctor sent me, or my husband said this, and, oh, we should probably do that, or I saw the ABC Catalyst program, or something. Someone will have mentioned exercise. And I guess the big thing is that we find out your diagnosis. We look at where you are in treatment, what you've maybe have already experienced, whether it is chemotherapy or surgery, what is planned, so we can better educate ourselves and yourselves, and moving forward in your treatment plan, knowing, hey, this is what to expect, and you may have fatigue because you're going through radiation therapy, or you may experience peripheral neuropathy because you are on this particular drug. So we are able to inform our patients and give them a bit of time, but say, hey, you know what? I think exercise can help, and can help with some of these symptoms and side effects, but also keep you strong during chemo, or keep you strong during the whole treatment process, to allow you to be better off at the end. The big thing is that, but I am physically active. I've got an active job, or I've got an active a garden, or I do the housework. And Shelley and I have a joke about the housework, because it can be dangerous to some of our patients. So with physical activity, it is basically something that is getting you to move, get your muscles working. So that is your housework, that is your gardening. But exercise in particular, exercise is prescriptive, it is repetitive, it is set out to do. You need to set time aside to be able to strengthen those muscles, to improve your cardiovascular fitness. And that is the big thing, the big message we want to say to people, is that it's not just about moving about at home, although, and I will put a little asterisk, that might be just enough for some to begin with. So it may be that I'm in bed and I can't do anything. I've been in bed for 6 weeks and I can't get up. So it might mean that walk down the hallway, or the walk to the letterbox, is enough to start. But in weeks to come, it might be, oh, I can walk a few houses down, or I can do around the block, or I can lift 2 kilos instead of 1. It is that slow progression, but it has to be set out and prescribed. we do want to know about your goals. And the biggest one is, I want to be stronger. And that is my favorite, because I love strength training. It's something that I do in my personal time too. So, you know, Shelley and I, we both practice what we preach as well. It's not just, this is what you have to do. And from there is carrying out, I guess, observations where it may be your heart rate and your blood pressure, seeing what your norms are, how you respond to exercise. So you might go for a 6-minute walk test, and then we check your blood pressure again. That from there, we look at functional fitness. So it might be your grip strength, it might be your leg strength. We get a baseline measurement of where you are in that bit of, you know, that frame of time, and we compare it 6-8 weeks later, see the differences. Have we improved? Have we maintained? And I think that's just as important as improvements. And from there is that exercise program where we think, okay, do you want to do the gym? Do you want to do something at home? Do you want to do something in the pool? Where do you want to go with this, and how can we help you? We really like the individual approach. We really like to know what people want. It's not just about what we think is best. Some people come in, and we've had a couple in the last couple of weeks. Shelley's going to go, yep, I hate the gym, I don't want to be in the gym. And we kind of go, uh-oh, what do we do? We've got to work within what these patients of ours want, and, you know, how we can maybe change that mindset just a little bit. And part of that as well is that education and planning for, you know, future consults, or what are we going to do in 4 or 6 weeks time? Or, you know, I want to be able to do 10 squats instead of 5, or I want to be able to get out of bed and walk around the house without feeling so tired and needing to sleep for another 2 hours. So things like that, where we are hearing our patients and trying to be really specific in or the type of exercise that we do give them. We're using this slide again because I think it's super important to talk about different types of exercise, being aerobic or resistance training, balance, flexibility. They all play a role in our prescription, and I guess playing a role in side effects and how we best overcome or help treat. So aerobic resistance and flexibility. So aerobic exercise. These are things that make your heart pump. It's all about the oxygen and breathing. So I've got a couple of snippets from Shelley and I's YouTube clips that we've completed during COVID. So we've got some boxing, we've got some swimming, dancing, running, cycling, anything that gets you to increase of heart rate or breathing rate or both, and gets that oxygen flowing. So that's super important. It could be starting off with a 30-minute walk. Again, that might be too much. We go right back down and we say, maybe we do a 10-minute walk in the morning and a 10-minute walk in the afternoon and see how you go. It's okay to break that type of exercise up, and it's okay to progressively increase it as well. So I'm not going to get someone to do all of it once, because that can be overwhelming and you'll probably feel quite fatigued and down and out for a few days if you've done nothing at all. So we start really basic, 5 to 10 minutes, and if a walk is a simple one, and progress from there. With resistance training, it is basically getting your body to move against a force, and that's to get your muscles to contract. Now, you can use your own body weight. That's a really simple way of doing some resistance training. So a simple sit to stand, getting out of your chair and having that repetitive movement is really, really good leg strength. It's also quite functional as well, because, we sit up and down out of a chair quite frequently, whether it's in and out of a car, at home, the dinner table, couch, toilet, all of that type of thing. We can use dumbbells or free weights. So they're super important, and they range from, 1 kilo to wherever many. And I hear there was a big shortage of those once COVID hit, because we had a influx of people starting up their home gym. And then you've got the typical resistance training machines that you can find in a gym, and that's shown in the bottom right screen there if you haven't been to a gym before. And then moving forward, you've got, you know, balance and flexibility. Super important to, I guess, keep mobile, have a, you know, good range of motion, quite supple. I know following breast cancer in particular, having good shoulder range of motion can get you, you know, reaching for the cupboard, the cups in the cupboard, or just being able to move your arms, super important. Balance exercises, as Shelley mentioned before, with that chemo-induced peripheral neuropathy. You know, I think it's really, really important as we age anyway to complete some balance exercises, but it's even more important when we start talking about things like the numbness and the tingling, and trying to get those smaller muscles and nerves firing. From there, oh, we got, okay, wrapping it up. Okay, I'm wrapping it up, almost done. The big question for us, and this is going to physicians as well, is why are we waiting till patients are so deconditioned to send them to rehab? I mean, some cancer patients are waiting around 6 to 10 weeks between diagnosis and surgery. So that's a really good time to start some exercise and to get you ready for you know, treatment. And I guess the mentality was always before, we need to rest before surgery, but now we use the term prehab. We need to get you ready for surgery. We need to get you ready for treatment, just to get you stronger and to improve that quality of life. I mean, there's structured programs for cardiac rehab, for pulmonary rehab, for after, you know, total hip replacements and knee replacements, but we're still, there's a big gap in oncology rehab or prehab. And I think that's a super important message to hopefully put out there. So in general or overall, we believe that exercise is medicine, and we believe that our patients deserve this medicine. And we are so happy to be part of that treatment process and plan. All done.
You have a quick film clip to show us we start going to our questions, and we are running a little bit over time. We've got some really interesting questions. So Angelique's just going to show you something quickly, and I will.
This is just a, where are we back to? So this is just a quick clip from our, from our group classes. They're a lot of fun. We love them. Let's do a play. Doing the car wash. Woo-hoo, Shelley. So yeah, just thought I'd share that quick clip. We've perfected the car wash.
You know, the gym is just down the hallway from my office, and when they start dancing, it's like a disco going on down the hallway. Thank you guys for such a fantastic presentation. Look, I know I didn't want to stop you talking, so we are at 12 o'clock. People who have to leave, we'll continue for another few minutes to just answer some of these really important questions. And I think the first question, I'm going to combine some of these questions. Shelley, the first one, is there any benefit for targeted therapy? So people not on chemotherapy. And another question is, what if I'm on immunotherapy or targeted therapy? Where is the evidence to suggest that there's a benefit in exercise? We talk a lot about chemotherapy. And if you could just comment on that.
Well, first up, exercise is an immunotherapy because it stimulates the release of natural killer cells. So the immunotherapies are trying to tap into a process to enhance and strengthen the body's own immune system. And exercise is doing a little bit of that. And exercise, in addition, is allowing that cloak of invisibility that's there, that's stopping, allowing cancer cells to evade immune surveillance. Exercise plays a role in that. Now, we had a study here which was exercising during immunotherapy, and my experience in the research area with that is somewhat limited at this point. But I think, Judith, you had the results of the exercise with immune therapy.
Didn't show the benefit. We showed the feasibility. We didn't show the benefit on immunotherapy, but there is a suggestion that it may further enhance the response to immunotherapy. I mean, it's a very complex space, but I think number one is it does no harm. We did show that people's fatigue improved, and we know that fatigue is one of the main side effects of immunotherapy. And so it's looking at symptom improvement as well. So I think it's a very interesting space which is being evaluated.
And so sometimes when we don't have evidence, we just look at the presentation of the person, what they're telling you that they're experiencing, we'll go with that, and then look at other diseases or other conditions that give us ideas about how to approach it, all the time knowing that we're in territory that's unknown, and we navigate cautiously.
Yeah. So the next question, I'm rushing through because I'm watching that, you know, people are starting to have to leave, is first of all, great presentation, Dr. Kay. I'm wondering, how do we address the psychological barrier to commence exercise? And secondary, how to maintain and make habitual beyond 6 months, beyond the supported interventions, and the and if you could comment on that. And the comment was, when is the Cancer Council program going to be digital? But I think that's all. I think the motivation is a very interesting space.
That's a very big discussion point. So yes, most people don't exercise even at the levels that are valuable for their health. Cancer is a very frightening experience, and some people will say that they're extremely motivated and they'll do everything. And I'm usually looking for the signs and the communication to know, is that real? Is that overdone? Does that mean that that person will be a boom or a bust? So my experience in diabetes prevention, I've learned to find out, is the person ready to change? What's important to them? Do they have the knowledge? Because knowledge doesn't change behaviour, but enabling easy changes in behaviour is part of what we do, and allowing people to identify where they want to start and have people create the opportunity to understand what their own barriers are and solve it themselves. So in the psychological context of physical activity and exercise, it's a big challenge. But with the approaches that we have some success with those who will come, even those who've never been to the gym ever in their life, and they say they hate it and they have exercise, and they're 77, and then they come and they're here for years. So that's an ongoing challenge. There are many disciplines that inform how we approach that, and I would like more funding for exercise research.
And I think that Memorial Sloan Kettering and some of the other major hospitals in the States are actually addressing this with health coaching and putting some money actually into health coaching, and having, because we've realised there is a barrier. There's one thing to say exercise is the best thing for fatigue. So in the Society of Integrative Oncology, for example, in the JCO article on breast cancer, they showed, well, you know, you can start actually with other things that make people feel good, like massage and acupuncture, because that can also improve fatigue. Meditation, there are other ways to approach fatigue, but ultimately our goal is to get people to exercise. So it's a combination.
Our job is also to...
What else can we do? And health coaching, and putting some money and some time into developing that field.
And telling people what to do doesn't work. So we're respecting people's autonomy and trying to engage where they're at.
Another practical question. Since COVID, I've not been able to use the gym for weight training. Can bands do everything needed?
Yes.
Angelique.
Absolutely. So we often, and I think Shelley's going to grab it, once COVID did hit, for the majority of our patients, we sent out an exercise pack. So we sent them some exercise bands that Shelley's demonstrating or showing over there. And we were also guiding them through, you know, some resistance band exercises. So yes, definitely they do range from super light, like the yellow ones, to the really heavy black and grey ones. And you definitely can do a lot of resistance training exercises with those. So I guess if that's the answer to the question, yes, definitely.
Yeah. And another part of the question is, how can you stop people from overdoing things because they have pre-cancer expectations of exercise capability, which sets them back as they have to recover from negative impacts on their immune system from over-exercising? Do you want to comment on that over-exercising space?
Angelique?
I've never experienced over-exercising, but
we commonly hear that.
You do get people that are over-exercisers.
Yes.
We commonly see that, and we do talk about that during our consultation. So I can only speak on what I do in my consults. So obviously, getting to know our patients is the big thing. So if we know that they're big on exercise, we have the time to educate them about what to expect during treatment. And we do warn about this potentially, or this may happen to you. So we talk about that boom bust approach of, I'm going to do everything, and you know, with go down the chemo path, it felt really good, and then they started with radiation and it just hit them like a ton of bricks, and they're in bed for days. So that's the gone, and we have to start back a little bit. So we do try and warn. At the same time, you know, I know the type of personalities, and I'm definitely I'd consider one of them, wanting to get things done and exercise. Sometimes you just got to also let patients make that mistake. You can tell them, you can give them all the information, not going to listen, that's okay. And that's human, that's what we do. If it then comes crumbling down and it's just a big, you know, blows up, we're there again to support them to go, okay, let's start again. And, you know, remember what happened last time. Let's start slow again. Remember when this happened. You try. We've got a few people, we've got to rein them in, just a few.
I think sometimes just giving people permission to do less is helpful, because we're looking at the guidelines and going, oh, well, I should be doing that. But we're talking about it relative to their baseline on any particular day. And also we listen to people, and sometimes there are anxieties behind those over exercises. And we're trying very hard to look at the chemo cycle or the radiation cycle and do periodized programming for week 1, 2, 3 or day 1, 2, 3. So we try really hard to meet the person where they're at, both in a physical and a psychological, emotional sense.
Now we're going to need to be starting to wrap up, and we've got some practical questions here. So first of all, can we refer ourselves to you if we're a Lifehouse patient? How do we get onto our YouTube channel? And what we will do is we'll be sending a copy of, so the YouTube channel is on the Chris O'Brien Lifehouse website, and it's called Living Room at Home. And we have a whole lot of short exercise programs that these guys have done. Some of them are very funny. They're really good. The answer to can you refer yourself, if you have a GP referral with a EPC, do you want to just talk about the referral process, Angelique or Shelley?
Sure.
So all centres, not just us.
So you can definitely refer yourself. However, if you do, or if you would like a rebate for our service, it's best to go through your GP, who can give you a care plan that entitles you to 5 subsidised visits from Medicare per calendar year. So, you know, yes, rock up, come and see us. If you've got private health insurance, there should be some subsidy with that too. But we often like to involve the GP and have the referral pathway through there.
And I think it's really important to engage and involve your GP, because they're that person that is with you for the long haul. Mm-hmm. And it means that there will be communication also from the exercise physiologists as to what you can continue with, what the benefit is, what the outcome, what program they've commenced. And we look at risk factors versus benefit. I always refer people, but you don't get the added bonus of a Medicare rebate if it's a specialist referring you, as opposed to a GP. look, basically, I think we're going to need to wrap up here. Any last minute questions? Resistance exercise been shown to be protective against lymphedema? The answer is yes. And having a personalised program is really helpful, and having a lymphedema assessment is very helpful, and that's something that we do. And just a few of the comments. Thanks, guys. Found this extremely beneficial and relevant to our work in the current climate. See you Monday, whoever that is. With the, I don't know the answer to the Enrich program if it is going online, but we do offer program either via Zoom or in person. So as the climate change, we've developed a really strong telehealth program. So we have people, and Angelique was going, and Shelley were going to show this film, that some of the people are there in the studio and the others are dancing around on the screen. So we do a mixed clinic and gym program.
Yeah.
So I would just like to thank you, Shelley and Angelique, for an absolutely wonderful and informative presentation. I'm so lucky to have these guys as members of my team. I think that this is a really interesting space, and I think we might come back to learning more about exercise in further sessions on in our webinar series of Living Well with Cancer. I don't know what our next session is going to be, so watch this space, and we'll have a few more sessions in the, once a month we'll be planning on putting a webinar together. And come and see us and come dance. Thank you very much, guys. Bye-bye.
Bye.
Bye.